Okay, so please bear with me. I take a weird medication called baricitinib, which has made it ridiculously slow to recover from this cold I got. So I still have a bit of a very residual dry cough that keeps coming up, and then occasional moments where I'll have excess mucus. And then there are times where I feel perfectly fine. Because I should have been okay from this like a week ago, but it's taking some time, but I'm doing the best I can. And trust me, I did sneeze before hitting go live, but it just doesn't want to end. Okay. So yesterday we talked about like the ego defenses and stuff. Pretty good list of like vocab words. A lot to know, but it's not really that hard at all. There are some words that I pointed out were a little more confusing than others, right? Like denial is very obvious. You'll know exactly what that means, but it's very possible during the stress and tension of a test to forget the difference between displacement and projection, forget the difference between fixation versus regression, and then the other ones were all related to reaction formation, such as reaction formation versus sublimation versus even altruism. Okay, so I talked about all of that in really nice detail. Within 1 hour, I was able to finish the whole chapter of just the whole section of just psychology. Now we're looking at psych pathology, and there's a lot of stuff here that often gets tested. NBME loves it, Step 1 loves it, and it's pretty easy. It's just understanding how things work rather than, crazy pathophysiology like we have in cardiovascular and neuro. So the first thing here is something called infant deprivation effects. Long-term deprivation of affection results in failure to thrive, poor language and socialization skills, lack of basic trust, reactive attachment disorder, where the infant is withdrawn or unresponsive to comfort, and disinhibited social engagement, right? So the child indiscriminately attaches to strangers, right? And these are all signs that, unfortunately, at some point we might have actually seen someone who had, okay? So especially the last two things can actually go on to adulthood, says that when this infant was growing up, they were, deprived of actual affection, actual care for the longest time. And when they grow up, they still have that same kind of, they have this reactive attachment disorder, which I don't think you would still call it that, but they have the symptoms of it. They will still choose to kind of shy away from someone that's giving them comfort, and they have this disinhibited social engagement where they'll do weird things like getting drunk or getting high and then just going with strangers. Okay, very weird thing that is very unfortunate. Deprivation for more than 6 months can lead to irreversible changes, and severe deprivation can result in infant death. Okay, so you from the RX talked about this thing called anaclitic depression. This is the lack of social stimulation which leads to unresponsiveness and physical decline, eventually leading to coma and death. Okay, so that's kind of what these infants end up going through if they have severe deprivation. And that was just a phrase that you from the RX mentioned, so I put it here. So this is pretty sad. This is usually seen in families that are, dysfunctional. Couples that didn't really want to stay together. Couples that didn't really intend to have the child, but the woman got pregnant and she decided to keep it, so the child was born. And it's cases like that that make abortion necessary, right? There's always a large debate going on about whether or not abortion should be completely illegalized, and the issue comes around to making it really hard to actually figure out where abortion is okay and where it's not okay. And in a case scenario where a couple was having sex and then the female got pregnant and now she doesn't want to keep the kid because the man she was having sex with is not someone she's going to marry, and neither does the man want the child, abortion is going to be very necessary there. Otherwise, you're going to give birth to a child that is probably going to live a very, very shitty life and possibly not even actually live. A lot of case scenarios. I mean, rape is another one that's a really big one, right? A woman that gets raped, if she's pregnant now and she doesn't want to keep that child because her life is revolving around so many other things like work and school, then she needs an abortion too. So all kinds of case scenarios can occur where an infant is born and then goes through severe deprivation. Child abuse is another scenario that's often also related to the same scenarios I was just talking about. So child abuse is now broken up into physical abuse, sexual abuse, and emotional abuse. Okay, this isn't the same breakdown they had before. Let me see. First day 2018. So before, they used to present it kind of like this, right? Just the physical and sexual abuse. Now they added this emotional abuse section. So what is this? Physical abuse: fractures, bruises, or burns, injuries often in different stages of healing or in patterns resembling possible implements of injury. Includes abusive head trauma, so shaken baby syndrome, which you have to be careful to not be confused by osteogenesis imperfecta. The main difference there is going to be the shaken aspect of brain injury. Shaken baby syndrome has brain hemorrhages, whereas osteogenesis imperfecta will not. Characterized by subdural hematomas or retinal hemorrhages, right? These things, subdural hematoma, retinal hemorrhages, these are things you would see in shaken baby syndrome, but not exactly in osteogenesis imperfecta. Caregivers may delay seeking medical attention or provide explanations that change or do not fit the child's age or pattern of injury. Okay, and you'll often see that in questions. Sexual abuse, STIs, UTIs, and genital, anal, or oral trauma in a child. Most often there are no physical signs. Sexual abuse should not be excluded from a differential diagnosis in the absence of physical trauma. So even if you don't see genital, anal, or oral trauma, if there's a sign of some kind of abuse occurring, sexual abuse should be up there too, and you should order a blood test to check for STIs, check for UTIs, urinalysis, all of that. Children often exhibit sexual knowledge or behavior incongruent with their age, because now that the child knows how sex occurs and what are some of the things you're supposed to do, they might actually talk about it. The last one, emotional abuse. This is new. So babies or young children may lack a bond with the caregiver, but are overly affectionate with less familiar adults. They may be aggressive towards children and animals or unusually anxious. Older children are often emotionally labile and prone to angry outbursts. They may distance themselves from caregivers and other children. They can experience vague somatic symptoms for which a medical cause cannot be found. This is a common one they put into questions. They love throwing this stuff into questions because it can throw you off and confuse you. So the child might say something like, their stomach is hurting excessively. Really bad stomach pain, they need to go home. Nothing's wrong with the child at all. It's actually just somatic symptoms just because the child doesn't want to be there. Doesn't want to be wherever they are in the question scenario. Maybe at the clinic they don't want to be there. Maybe they don't want to live with a caretaker. Maybe they don't want to go to school. Some kind of weird thing that doesn't really fit. And there's the breakdown here between older children versus young children, right? So young children, because their caregiver is so emotionally abusive, they try to stay away from the caregiver and are more affectionate with other, less familiar adults, right? Strangers. They like being with strangers because they know or they feel that the stranger is not going to be emotionally abusive. But their own caregiver, someone they're supposed to be comfortable with, familiar with, is abusive. So that's one thing that the younger children do, and then the younger children will do this thing of bullying, basically, right? Maybe aggressive toward children and animals, or unusually anxious. So now, who does it and how common it is the next thing that you need to know. So with physical abuse, it's usually the biological mother, right? And if you're wondering why, then it's usually because of one of the scenarios I said before, right? She didn't want the child. She did not want the child. Either the child was forced onto her, either the child came from a rape incident, came from a man she really didn't like, something like that. So it's usually the biological mother that does the physical abuse. excuse me, 40% of deaths related to child abuse or neglect occur in children less than 1 year old. Okay. Sexual abuse. This is usually a male that is known to the victim, right? So some child who is being sexually abused by a male. Okay. Females, like mothers mainly, will not be the one to cause sexual abuse, but the male will be the one that will do the sexual abuse, and it's usually a male that the child knows, maybe some uncle, maybe some male caregiver, something like that. Emotional abuse can be anybody. Okay, any caregiver, anyone that was supposed to be taking care of the child, but doesn't really take care of the child, they're just doing the job for the money or something, and that just really sucks, right? So now 80% of young adult victims of child emotional abuse later on end up meeting the criteria for more than one psychiatric illnesses by age 21, right? Long-term effects, because they were brought up in such a terrible environment by such a terrible person. So all you gotta remember is the mother slaps the child, the father rapes the child, and the caregiver threatens the child, right? These are the general scenarios we're seeing here, right? So physical is mother, sexual is dad, and emotional is a caregiver. This is a Euro question here, which shows you how weird the scenario can be, and that's, you're supposed to get a feeling when you read these questions about child abuse, and you should know that it's child abuse. Like, if you're confused about child abuse, then it's probably not child abuse. Otherwise, you'll know. It's going to be very evident. Look at this question. 6-year-old boy is brought to the emergency department by his parents for an asthma exacerbation. This lotion is not melting in my mouth since I'm talking. A 6-year-old boy is brought to the emergency department by his parents for an asthma exacerbation. During the examination, the physician discovers a well-demarcated round burn mark on his thigh. When asked about the burn, the patient says, "That happens every time I'm bad." So now you're supposed to feel really like, something's shocking here, right? The well-demarcated round burn mark is a cigarette burn, right? So that means that that's literally physical abuse, right? You're not supposed to be burning out your cigarette on your child. His mother corrects him and says that it was an accident resulting from the boy playing with the cigarette lighter in the car. Which of the following is the best next step in the management of this patient? Now look, it told you here, caregivers may delay seeking medical attention or provide explanations that change or do not fit the child's age or pattern of injury. This 6-year-old boy would not be playing with the cigarette lighter in the car. Now, they purposefully chose this concept of a cigarette lighter to confuse you and kind of make it feel like, oh yeah, that makes sense, and then you just play along with the question, right? A lot of people don't actually know what a cigarette lighter of a car is, okay? And it's not a cigarette lighter. A cigarette lighter is something that you can flick it, it gives you fire, and then you can actually go ahead and burn your cigarette. But this is what a cigarette lighter of a car is. We've all seen it. It's that thing you use to charge, right? It's that thing you use to charge your phone in the car. The reason it's called a cigarette lighter is because there are actually forms of it that could be used to burn a cigarette too. But in today's cars, they're not built for burning cigarettes at all. They're literally just chargers. They're just chargers, okay? So they're saying that the baby used this portion, the 6-year-old kid used this portion of a cigarette lighter and somehow burned himself. But that's really ridiculous, because this portion of the cigarette lighter, no matter how much you're using it, no matter how much you're charging stuff in your car, this thing doesn't get hot. And definitely doesn't get so hot that it's going to cause a well-demarcated lesion like the one the mother is trying to explain. So you can see how the mother's explanation doesn't really fit the scenario. It's very unrealistic. So based off of that, what would be the next thing you do? You would seek permission from the parents to interview the child alone. That was the answer choice you had to pick, right? Because the child is your patient. So you now see a problem. You want to make sure you're able to talk to the child without the parents intervening. If everything's okay, if the parents have nothing to worry about, they'll let you do it. The interview should begin with non-accusatory, open-ended questions followed by more specific inquiries about how the injuries occurred. So your question can actually be about that too. So don't be like, your mother did that, didn't she? Don't ask leading questions, right? Don't say something like, your father was the one that burned your leg, didn't he? Don't do that at all. You're just supposed to ask open-ended questions. Hey, so you said that this happens every time you're bad. Can you tell me more? Right? And he'll tell you, yeah, one time I ate candy and I wasn't supposed to, So my dad got mad and he was smoking a cigarette and he sat me down and he burned my ankle or whatever with the cigarette. Right? That's physical abuse, very common thing. It can be either the father or the mother, but usually is the biological mother. Okay, and you can see here in the question, it is the mother that brought the child in. Parental refusal of interviewing the child alone is concerning for abuse. The child should be examined for genital trauma, retinal hemorrhages, and neglect, right? Because anytime you have physical abuse, you also want to check for sexual abuse, right? So this should not be excluded. Very important thing, right? It should not be excluded from a differential diagnosis, even if there's no actual trauma. Physicians are legally obligated to report suspected child abuse to Child Protective Services as soon as a full evaluation is completed. From there on, Child Protective Services will take care of it. The next thing here, child neglect. Child neglect is the failure to provide a child with adequate food, shelter, supervision, education, and or affection. Most common form of child maltreatment. Evidence is going to be when the child comes in, you're going to know the child has poor hygiene, malnutrition, withdrawal, impaired social and emotional development, and a failure to thrive. The failure to thrive part might not be so evident, but the most evident thing will be the impaired social and emotional development. And they're going to try to confuse you in these questions by telling you, answer choices such as the child has ADHD or the child has some kind of other, psychological issue. It's none of that. If they tell you poor hygiene, right? No child should have poor hygiene. There's no reason. Parents, one of the top jobs of a parent is to make sure your child is brushing their teeth, staying groomed, showering every day, etc., etc. So the child has poor hygiene. That's a huge giveaway for child neglect, and then everything else is just an outcome of the child neglect. Okay, and as with child abuse, suspected child neglect must also be reported to local child protective services. The last one is vulnerable child syndrome. This one is pretty weird. This is pretty interesting. I have seen a question on this too. I think this is that. No, this is not that question. I have seen a question on vulnerable child syndrome too, though. Here, parents perceive the child as especially susceptible to illness or injury. Usually follows a serious illness or life-threatening event, can result in missed school or overuse of medical services. But the true problem here is with the parents, not the child. Okay? Vulnerable child syndrome is an issue with parents. So these parents, maybe this child had maybe this child had leukemia and was able to recover from it. Now the child's alive. But the parents are going to be so overly concerned. They're going to keep making sure the child is at the hospital every other day, checking up for everything, making sure the leukemia isn't coming back, etc., etc., etc. They'll keep doing it. That is something called vulnerable child syndrome. You want to make sure you cast that correctly. Don't pick other answer choices like Munchausen syndrome or those other things that we're going to see soon enough. UWorld has another question right here. This is about child abuse as well. This one says, a 1-month-old full-term boy is brought to the emergency department by his mom for difficulty awakening. The mother says the infant was left alone for a few minutes and rolled off a bed. Since then, he has been sleepy and less active than usual. Physical exam shows a lethargic boy with large, full anterior fontanelle. Bilateral retinal hemorrhages are seen on fundoscopic exam. Which of the following should be strongly suspected in this patient? And this is an extremely easy question because they're asking you what should you suspect. You should suspect abusive head trauma, formerly known as shaken baby syndrome, which results in retinal hemorrhages, posterior rib fractures, and tearing of bridging veins leading to subdural hemorrhages. Right? And you can see again, the mother tried giving a story. And it's a story that doesn't really necessarily fit, right? A 1-month-old full-term boy, and they tell you full-term, so you know it wasn't born premature. A 1-month-old boy rolled off the bed and fell. What are you doing? You have a 1-month-old child. You should be taking much better care than to let something like that happen. And let me see something, UWorld. UWorld had a really nice image for shaken baby syndrome. I'm not sure if I'll be able to find it. But they also showed the posterior rib fractures in that as well. No, I can't find it. Usually you can find some of these UWorld pictures online very easily. But not this time. I could have sworn I even had the picture, but maybe I'll find it another day. But it was a picture of like two hands holding the baby up and shaking the baby like this, and you could see that because of the force that you're grabbing the baby with, it often ends up breaking the posterior ribs, right? Because of the way you're holding the baby to shake it. You're mad at the baby, you're practically beating the baby, and that posterior rib thing is another giveaway. If you have a infant with posterior rib fractures for no real reason, then again the question will have something like, oh yeah, we were playing with the kid and then I dropped it, something stupid like that, and that's why the posterior ribs broke. No, it didn't. You beat the child. You're having physical abuse at home. We're calling the cops. Okay, that's it. Now, next page goes on to childhood and early onset disorders. So this is kind of where, the psychiatry really kicks in. Stuff starts getting a little harder, and you want to make sure you know each of these very well. I was telling you guys yesterday that a lot of things in first aid need to be repeated and revised. Psychology, the whole list of ego defenses was not one of them, right? You were supposed to master them the first time you read it. Spend the entire day on it if you need to, but make sure you master it before moving on to anything else, because you don't want to keep coming back to it. It's not one of those topics that needs you to come back to it. All these disorders, you don't really need to spend another day to come back and study them again. You will revisit these disorders as you do questions where you see them in the answer choices, or if they're actually the correct answer. Okay? So make sure that the first time right now, when we go through all of these, you are able to grasp it correctly, understand what is unique or what is specific to each one of these disorders, and how to differentiate between one over the other. So the first thing is one we're all commonly associated with, ADHD. We've all seen this. We've all known someone or do know someone who has ADHD. Onset of ADHD has to be before age 12. It has to last more than 6 months, of limited attention span and or poor impulse control, characterized by hyperactivity, impulsivity, and or inattention in multiple settings. And that's it, nothing else. Okay, so limited attention, hyperactivity, impulsive, or inattentive. In school, home, church, wherever. Normal intelligence, very important. So they're not stupid. They're not hard to educate. They have normal intelligence, but commonly coexist with difficulties in school because they're not paying attention. It's not that they're not intelligent. They don't have any mental retardation. They just don't pay attention. So if you're not listening, you're not going to learn. Often persists into adulthood. Okay? But the onset of age has to be before age 12. Treatment is giving stimulants, methylphenidate, plus or minus cognitive behavioral therapy. Alternatives include these medications: atomoxetine, guanfacine, and clonidine. Clonidine and guanfacine are alpha-2 agonists, lightly discussed under pharmacology. Atomoxetine is a norepinephrine reuptake inhibitor, amongst many other things. Right, so when you get to those medications, make sure that when you see clinical uses of those medications, it should say ADHD as well. Okay, somehow those other medications help with ADHD by helping them have better attention, less hyperactivity, less impulsivity. Alright? So generally speaking, normal intelligence, no mental retardation, just doesn't pay attention at all. Under age 12. All of those four things mix into each other to give you ADHD. Next one is autism spectrum disorder, ASD, characterized by poor social interaction, communication deficits, repetitive or ritualized behaviors, which is a giveaway, and restricted interest. Must present in early childhood. May be accompanied by intellectual disability, so they don't need to have normal intelligence. They could have low intelligence. Rarely accompanied by unusual abilities. The fuck, man? Rarely accompanied by unusual abilities called savants. More common in boys, associated with increased head or brain size. I can't wait to be at 100% again. So the repetitive ritualized behaviors part is the one that really is often going to be very confusing, and they'll try to present it to you in a question where it kind of feels like it might be ADHD or something. But remember, ADHD didn't have any kind of repetitive behavior. So in one question I had seen, I saw repetitive behavior, the one that I'm explaining right here. Repetitive ritualized behaviors can be like running around a table before sitting, or going under the bed before sleeping on it. Right? These are just minor silly things, but they're weird. They're not things that we know kids do. Right? So there was a question in UWorld where, this kid was brought into the clinic to be examined, and this kid has a tendency of walking around the chair a couple times before actually sitting down. And the kid does it in school too. So it's a behavior. It's not just a one-time thing. It's a behavior. This kid does it all the time. That is an autism spectrum disorder thing. Okay. Restricted interest. It was also seen the kid really wasn't interested in anything in the clinic. And remember, most child clinics will have like little toys, wonderful little things, cute things that the kid will really be into. They're not there just to entertain the kid. It's actually there for diagnostic reasons. Doctors are able to see the fact that the child is not interested in any of the cute little toys that are in the room. And the savant thing, unusual abilities, right? This is another thing, very rare, right? Most kids won't have a savant, very rare in questions too, but it's basically going to be something like, the kid has the ability to, what was one I've seen? No, I can't really think of any good unusual savants. Let's see if we can find something. Unusual savant. So, something that's keys are like mind reading. See, like mind reading, savantism and autism. So this is a kid that is probably really good with the piano. Something like that. Something that you would think is sort of gifted, but it's really not that gifted. It's more like a savant. So you can see here, this is actually a really cool image. So this one is showing you this kid, probably on the autism spectrum disorder, has a savant where he's unusually good with math. In fact, this is a triple integral he's doing right here. Okay, so he's doing upper level calculus. He probably learned it by himself. Whereas here, this is hyperthymesia. This is just a kid who's just very, very good at learning. So he's sitting there and reading, but he doesn't have autism spectrum disorder. Okay. Now, having a savant is actually pretty cool. It's a good thing, right? So it's something that you're unusually good at, and that's perfectly fine. A common example of a savant. There you go. I just remembered now. There's a show called The Good Doctor, right? Really interesting show. He's a young kid, and he's unusually good with medicine. He just knows everything, right? And that's what makes the show so entertaining. He's better than all of us combined. He's able to solve all kinds of medical issues, even things that upper-class surgeons and upper-class long-term practicing doctors are unable to resolve. He figures it out just by spending a little bit of time with the patient. So that's what that's about. He is on the autism spectrum disorder. So that's his unusual savant. Okay. Conduct disorder. This one's actually really easy, right? Having good conduct is a thing that we teach all of our kids. Conduct disorder is repetitive, pervasive behavior violating societal norms or the basic rights of others. Aggression to people and animals, destruction of property, theft, right? These are all the things we teach our kids not to do. Don't fight anybody, don't hurt animals, don't destroy other people's property, don't even touch it, and don't steal anything. So, bad conduct. That's all this is, right? Conduct disorder. After age 18, this is often reclassified as antisocial personality disorder. Okay? And we're going to see that when we get to our personality clusters. Treatment for both is just psychotherapy, cognitive behavioral therapy. Conduct disorder will often also be something that they're trying to confuse you into picking one of these other answer choices, so make sure you see the difference. Conduct was very straightforward. You're just not having good conduct. Disruptive mood dysregulation disorder. This one has an onset before age 10. Severe recurrent temper outbursts out of proportion to situation. Child is constantly angry and irritable between outbursts, and this is probably as a result of child abuse or emotional abuse at a much younger age. Okay, treatment is to give stimulants and antipsychotics. Very unfortunate thing, but it's a dysregulated disruptive mood. The name of the disorder is very well made, so you won't have an issue understanding what it does. Okay, dysregulated disruptive mood. The temper outbursts are something you're not supposed to see in a child of age 10 or below. Intellectual disability is just a global cognitive deficit compared to specific learning disorder, which we're going to see later on. So this is global. This is like they can't learn anything. Intellectual disability affects reasoning, memory, abstract thinking, judgment, language, and learning. Adaptive functioning is impaired, leading to major difficulties with education, employment, communication, socialization, and independence. Treatment is comprehensive, multidisciplinary support to improve global functioning. So this all comes from special education, which is heavily funded and very well done in America. Psychotherapy, speech therapy, and occupational therapy. You have to get all of these things done for any child that you might have with intellectual disability, right? Without these therapies, they will end up never having learned anything and pretty much socially dysfunctional, right? So that's really unfortunate. So do not disregard that. ODD, oppositional defiant disorder. Again, another one that's really perfectly named, and I'm grateful for these being named pretty well. So you defy any opposition, okay? Enduring pattern of hostile, defiant behavior toward authority figures, but without serious violations of societal norms, right, or social norms. So what are they trying to compare this to? They're comparing ODD to conduct disorder. Conduct disorder, you violate societal norms, right? So you're stealing things. In oppositional defiant disorder, you're not going to go steal things or destroy other people's property. You're simply not listening to authority figures. Okay, that's what oppositional defiant disorder is. You defy any opposition from any authority figures, right? Only people that should ever be opposing you are people that are above you, either because they're either because you owe them something, or they're your parents or something like that, right? Or your boss, etc., etc. So when you see stuff like that, that's when you start thinking, okay, that's ODD. And that question, I'll be honest, that question could have something where the child might have destroyed some kind of property, not going to have theft, should not have theft at all, might have beaten somebody up, something simple like that. You know, it could have it, but the main concept of that question stem is going to be the fact that they're disregarding some kind of authority figure, right? Not listening to the principal, not listening to their father, their mother, not listening to their boss, something like that is going to be there. That's oppositional defiant disorder, where in conduct disorder, it has nothing to do with not listening to someone. You don't listen to anyone. You're just doing whatever you want to, and you're doing bad things, okay? Selective mutism. Perfectly named, selective mutism. You're just mute. Often onset before age 5, anxiety disorder lasting more than 1 month, involving refraining from speech in certain situations despite speaking in other, usually more comfortable situations. So, selective because you choose where you're going to be quiet, but when you're comfortable somewhere, you talk a shit ton, right? Development, speech, and language are not typically impaired. Okay, so development is not impaired, so their speech and language abilities should be outstanding in some kind of setting. So maybe whenever this person goes to school, they don't talk at all, right? Or whenever they go to sleepovers that you make them go to, they don't talk at all. But when they come back home, they talk a lot. Or maybe they have a circle of friends they don't talk at all with, but then that one friend they're very comfortable with that they tell long stories to and discuss everything. Selective mutism. Interferes with social, academic, and occupational tasks, commonly comorbid with social anxiety disorder. Treatment is behavioral, family, and play therapy. Very important to understand this. Okay, they're going to have these things as answer choices. You don't want to jump to just giving medications. SSRIs are fine, sure, but generally speaking, you want to do these therapies first. Now, we all know cognitive behavioral therapy. Family and play therapy is when you actually have therapy with the family. So everyone does something together, right? This is going to be necessary in scenarios where the selective mutism might have actually selected to be mute with family, right? So if the child never talks at home, but talks a lot at school, that's because for some reason this child is not comfortable with the family. So you do family therapy, you all do something fun together, right? And the doctor's going to be a part of this too. So the doctor or the therapist is going to tell you, as a family, go on a picnic, make sure you guys bring some games to play, do this, do that, do whatever the child likes. You're serving the kid to make him feel better, right? And same thing with play therapy. Maybe the child doesn't like going to school and talking at school at all, right? Doesn't like playing with the sibling at all. Something like that. So you have to make them play together so that the child starts feeling more comfortable. The main end goal here is to make the child feel comfortable. So all of these things are going to be ways to make the child feel more comfortable so that they can stop being mute. Separation anxiety disorder. Separation anxiety disorder. Overwhelming fear of separation from home or attachment figure lasting more than 4 weeks. So basically a month. Can be normal behavior up to age 3 to 4. May lead to factitious physical complaints to avoid school. Okay? So separation anxiety disorder, these factitious physical complaints don't just lead to, or don't just occur for avoiding school, they actually also occur to just go back home. There was a question, I'm sure many of you have probably seen it, where some girl is supposed to go to her friend's house for a sleepover, and when she gets there, she starts complaining non-stop about her stomach hurting. She keeps crying about it until the mother comes to pick her up, and then as soon as she gets back home, she's perfectly fine. Okay, so these are all just complaints that the child is making up, not because the child actually has a problem, but only because the child wants you to call their parents, and then the child wants to go back home. Okay, so separation anxiety disorder, just hate being away from parents, hate being away from whoever the caretaker is. Treatment, again, is just play therapy and family therapy. Make sure you're getting the child to understand that the parents are not going to be gone forever. Right? The parents will come pick you up again eventually. You will go home again eventually. Right? That attachment needs to be resolved, and the child needs to be able to attach with others and be comfortable alone after a certain age, you know? And it's normal behavior up to age 4. So if you're 5, 6, 7, you can't do that. Now, this is easy to remember because in America, you practically start school at age 5. At age 5, you start first grade, right? Or kindergarten, stuff like that. So, up to 3 and 4, those are the times you're still home because you're going to have some kind of separation anxiety. You're going to feel weird being away from home, being away from your parents because you've been with them this whole time. It isn't until after age 4 that you start feeling like you're a little more ready to go out on your own and do things. Okay. Next one, specific learning disorder. This is the one you're supposed to compare to global cognitive deficits of intellectual disability. Specific learning disorder is onset during school age years, so after age 4. Inability to acquire or use information from a specific subject, math, reading, writing, near age expected proficiency for more than 6 months despite focused intervention. Okay, so I worked with a child once. I worked for this company called the New York City Foundling. They provide educational services for, I guess, poorer families that don't have the money to actually hire upper level tutoring. And the family doesn't have to pay anything, the company pays. So I was working with this one child. The child had a really bad experience in family because of divorces between parents and moving and relocating school and stuff like that. The child was no longer able to really learn any reading or writing at all. Right? Both of these things. He was just fine with math, but when it came to reading and writing, he would read the story and he would have extreme difficulty reading the story. And then when he would get to the questions, which were very straightforward for his age, he wouldn't really be able to figure it out. Okay, so despite focus intervention is a critical part. I was the focus intervention. I actually worked with the child for over 6-7 months, really tried to help the child get better at reading and writing, and he did improve quite a bit, but his family scenario was so bad that it was hard to actually keep him going because, I can only do so much. His parents also have to help, siblings have to help, someone else in the family also has to be there to help his mentality get better, and it wasn't really happening. I felt like every time I left him, he just regressed and forgot everything again. So it was pretty difficult. And these learning disorders, any of these disorders for the most part, don't always occur because they just occurred. Oftentimes they're related to some kind of family issue, right? Big family issues. So this is one of those things that can be related to family issue. General functioning and intelligence are typically normal, right? Versus intellectual disability. Remember, in intellectual disability, they don't have the ability to socialize, communicate, right? Be independent, all of that stuff. This kid was just fine. He met me very nicely. He spoke to me very nicely. He would tell me about his day. I would ask him every time I met him, like, how's your day? What'd you do at school today? He would answer everything just fine. He just couldn't work with reading and writing questions at all. Okay? Often comorbid with chronic illness, psychiatric conditions, other learning disorders, Treatment is academic support, counseling, and extracurricular activities, all of which are things that require a family, right? If you're a young child, school age years, and your parents are having really, really bad trouble between each other, it's going to be very hard for the child to get these services because the child can't just go to these services by himself, right? The family has to set it up. Last one on this list, Tourette syndrome. Onset before age 18. We're all very well familiar with Tourette syndrome, characterized by sudden, rapid, recurrent, non-rhythmic, stereotyped motor and vocal tics that persist for more than 1 year. Coprolalia, which is the involuntary obscene speech, cursing out of nowhere, is found in only 40% of patients, which is still a lot. Right? 40% of patients is a lot, so a lot of them will have coprolalia. Associated with OCD and ADHD. Treatment is psychoeducation, behavioral therapy. For intractable and distressing tics, high-potency antipsychotics like haloperidol and flufenazine can be helpful. Tetrabenazine can be helpful. Alpha-2 agonists like guanfacine and clonidine, once again, the same medications you would use for ADHD. Or atypical antipsychotics, right? So you might actually have to tap into those things. Another thing I had seen on YouTube actually was that a lot of Tourette syndrome patients are able to use music to control their tics, right? So when they're listening to music, the whole rapid recurrent stereotyped motor and vocal tics calm down, and then they're able to like function better than they would with the tics and stuff. Right, so there's always all kinds of stuff like that that you can actually see in a question. Don't get thrown off. It is still Tourette syndrome. Make sure that when you're working with psych questions, you focus on things you actually care about. Symptoms, age of the child, right, and anything that makes it better or worse. Don't care about the other extra stuff that's in the question that's really trying to throw you off or trying to make you pick another answer choice. Okay? So really nice list of stuff. None of these are heavily overlapping each other at all. They're all very different from each other. Make sure you catch them this first time right now. So if after watching this, if you just watch the whole video, go back and read it all again by yourself. Make sure you're able to talk about them. Make a list where you write these out and then tell me what they are yourself, without the book in front of you. So on your list, when you get to conduct disorder, be able to tell me that this is just a disorder of conduct. You just act and do things you're not supposed to do, like stealing, fighting, breaking things, and it has nothing to do with other people. You're just a bad person. You're a bad child. Compare that to oppositional defiant disorder. You don't necessarily do those things, but you're still very hostile only toward authority figures, toward somebody that's trying to have authority over you. Oftentimes this occurs because you don't want that person to have authority over you. Okay, so this can be seen in scenarios where a step parent might be involved, right? Like a stepmother will often try to have authority over you, and you might not have wanted a stepmother, so you're going to start fighting back, right? And this is something that young children do very commonly. And that's about it for those guys. Last thing on this page is orientation. This is something that we test for all the time, right? When patients come in and they don't look like they're in the right mental capacity, you ask them, do you know where you are right now? Do you know what day it is today? Do you know your name? So patient's ability to know who he or she is, where he or she is, and the date and time. Common causes of lost orientation are alcohol, drugs, any kind of fluid or electrolyte imbalance, which can commonly occur in patients who are maybe, maybe in a burn, so that would cause a fluid electrolyte imbalance. Maybe someone who's had extreme diarrhea for a long time. Maybe someone who kind of fell in the bathroom or kitchen and didn't get help for the longest time, so they're pretty dehydrated. It can occur in head trauma, obviously. Hypoglycemia, another scenario of being stuck somewhere and not being able to eat. Infection, nutritional deficiencies, and hypoxia. The infection one will usually be seen in elderly patients. All right. So these are the things. So you always check for time, place, and person. TPP. Time, place, and person. What time is it? Where are we? What is your name? And this is the order of loss. So the first thing people forget is what time it is. And we never know what time it is, right? We always have to check what time is it. Where you are is the second thing you'll forget. And then your own name is the last thing you should forget. Okay? So that's it for now. In the next video, we'll continue on into amnesias and then have a big chat about the differences between delirium, dementia, and delusion. All right, thanks a lot for joining, and then I'll see you guys next time.